Welcome to Stall Side Podcast.
But how goes it?
Very good today. How are you, Peter?
Living the dream, but nightmares are also dreams.
Yeah.
So on the show today, we've actually got one of our friends coming back.
We do. Scott Morrison's back with us. He was with us once before. Very popular show, and we've had some people ask for him, and I'm going to talk specifically about foundered horses.
Yeah, this is actually quite a big request amongst the listener base, was to actually have Scott come back and talk about this. And it's a lot more complicated subject than I think people realise. I think it's multiple different causes, and I think that it'll be good to have him come along and actually lay those out and look at his approach to how he treats the horses that have the individual categories, because it's just not like a one-size-fits-all. You can't cookbook these things. I'm looking forward to seeing what the master does in these situations, because they're not all the same.
Right, and those guys can recognize that so well, and they have so much experience, and Scott's been a pioneer of this, as we've said before, so great to have him back.
Yeah, it will be good. So coming up next, Dr Scott Morrison from the Rood and Riddle Podiatry Service, and he's going to concentrate on laminitis. See you soon. Scott, welcome back to Stallside.
Thank you for having me back.
It's really good to see you.
Yeah, no, the last show went really good, and we've had some listener requests that you come back.
Oh, wow.
So, yep. So, want to take a little bit deeper dive into laminitis and talk about that. So, there's a lot of interest. So, we're glad to have you here.
Oh, good. Hopefully I can help.
Yeah, absolutely. Probably start off by, there's a lot of terms used, right? Laminitis, founder. Are these interchangeable?
No, not quite. Laminitis doesn't equal founder, but founder equals a history of laminitis.
Mm-hmm.
So, laminitis basically is inflammation or compromised lamina, which leads to founder. And founder is when the coffin bone actually displaces. So once the coffin bone actually moves, we call it founder or chronic laminitis. So you can have acute laminitis, or just have inflammation with no movement of the bone. Mm-hmm. And 100% reversible as far as we know when they have acute laminitis. But once they founder, they never heal back 100%. They're always compromised to some degree.
So you could think of founder as like an end-stage laminitis.
Yes.
over a long period of time? Okay.
Yeah, that's the sequence you don't want to go down. You can either go from laminitis to recovery or laminitis to founder, and then different degrees of healing once they founder.
Okay. And people sort of think about laminitis, but I think we touched on this in your first podcast. There's not really like one sort of cause or one thing. So as you divide this up in your mind, could you sort of explain to the listeners different sort of types, different scenarios, maybe different mechanisms, and do they all end up in the same place, or is there really like a common clinical presentation at the end of this, but you may get there by different pathways? So how do you work this out in your mind?
Yeah, there are different ways. There are different types of laminitis. We used to think all laminitis was the same, but with time we've divided them into three different categories based on the cause of laminitis. So the three basic causes would be, laminitis secondary to some endocrine abnormality, such as equine metabolic syndrome or Cushing's disease. So that's one pathway. Another way is the kind of the catastrophic laminitis cases, secondary to some systemic infection, like a colitis or pneumonia, would be the most common systemic causes. So basically some systemic inflammatory condition leads to laminitis. And then the third one would be the supporting limb laminitis cases. Those are the ones where horses are bearing weight on one limb excessively, and that causes some things we can talk about, some perfusion deficits in that foot that can lead to laminitis. And then there's probably a fourth one. You hear in the old textbooks, road founder, more of a traumatic, mechanical kind of laminitis. So that could potentially, that's probably a fourth mechanism of getting laminitis.
Right.
Just excessive concussion and excessive mechanical stress on the foot can cause some detachment.
Yeah. Getting back to the support limb laminitis, because I know that's us in the hospital, we really fear that one, and I know the surgeons do too that do the orthopedic surgeries. You're talking about the mechanism of that. So how does a support limb laminitis come about?
Yeah, well, horses are designed for constant movement. if you just imagine a horse's long legs with no musculature, they need to move to return blood, back up to the back up to the circulatory system or back up, towards the heart. So, even horses standing still are never completely still. They're what we call quasi-static. They're always shifting weight. In fact, there was a study done by Dr. Hood and one of his grad students years ago where they actually just put normal horses in stocks and just measured how many times these horses were on force plates in stocks. So they were able to see how many times horses shifted weight. And a normal horse shifts weight 125 times an hour. So just imagine a horse that's severely lame on one foot and just constantly standing on one leg without that quasi-static shifting or moving. And it does lead to some perfusion deficits. And those perfusion deficits are a consequence of a normal, the normal physiology of a horse's foot. I mean, the foot does some weird vascular things to help it absorb shock. There are studies showing the horse's foot can absorb so much shock. Like just imagine a racehorse running down a track. The amplitudes of the vibrations generated at ground impact are decreased by 90% by the foot before they reach the pastern. So the foot has a huge capability of absorbing shock, and a lot of that's done by blood flow and perfusion. Just imagine a horse's foot swinging through the air. That centripetal force kind of pushes a lot of blood into the foot. The foot hits the ground with tremendous pressures, and that tissue is being squeezed, and that blood flow is then pushed back up the limb. But I don't want to get too far in the weeds or make this too complicated, but the blood flow has to go from arteries to the capillary bed into the veins. And if you imagine the tremendous pressures generated when that foot contacts the ground, that blood, there's so much pressure that blood would push back up, retrograde back the wrong way up through the arteries. So there are some, different mechanisms in place to clamp off blood flow to the foot when it's fully weight bearing to ensure, unidirectional, arteries, capillaries, veins back up the limb, to preserve that vascular pattern. And when the foot hits the ground, those palmar digital veins are kind of pinched off by the deep digital flexor tendon. And we have some arteriograms and some vascular studies that we've just done just to demonstrate that and show it. And it's been studies that's been done a long time ago. We just reproduced it for our own interest to see. But those vessels, those arteries and veins are actually pinched off. And so when a horse is fully weight bearing, the arterial and venous, those vessels are, I'm sorry, I said venous, but the arteries are actually pinched off. The arteries are pinched off to stop the blood from retrograding back up through the arterial bed. So it's it's a shock absorbing mechanism that just goes wrong. Horses are not supposed to stand fully on one leg for prolonged periods of time, or that those perfusion deficits will actually shut off blood supply to the lamina.
That's pretty impressive physiology. You think about a horse galloping.
Yeah, they do it every time.
It's striking multiple times. Yeah, maybe a second.
Yeah, multiple times. It's, if you look at the architecture of a horse's foot, it's a small, it's a pretty small piece of architecture that absorbs a lot of shock and concussion and supports the entire weight of the horse. And a lot of that, so the horse doesn't rely completely on the architecture of the tissues. It relies on blood flow, turgor pressure, fluid within closed spaces to help support and absorb shock and help support that foot and help it take on that task of absorbing shock and concussion. So it's a bioengineering. The foot always amazes me. It's a very complicated little piece of anatomy on a horse that does a lot of amazing things.
It is very complicated. So we think about laminitis as being a four-limb bilateral affecting both leg disease. I guess this, having overload as the cause, is that the only exception where it might be unilateral and it could be a hind limb?
For support limb laminitis? Yeah, you can have, most support limb lamina cases are just one foot, but it can be, I've seen supporting limb laminitis cases be, it's not typical, but I've seen it be, the healthy front foot and both hind feet as well.
Gotcha.
But they can founder, a supporting limb laminitis can occur in the front foot or in the hind foot. Yeah, and that's different than our other types of laminitis, right? The other types of laminitis, usually they're four-limb, usually bilateral. Is that accurate? That's accurate.
Yeah. And occur sort of about the same time.
Yeah.
Yeah.
Yeah, I mean, one foot is usually affected worse than the other based on the anatomy of the horse's foot. Like if a lot of horses don't have two symmetrical feet. A lot of horses will have one low heel foot and one upright foot. And the upright foot typically founders worse than the low heel foot. It's because there's more tension on the lamina and the toe on the club foot.
Yeah.
I have a theory that I think the lamina are compromised uniformly around the whole hoof, and just the part of the foot under the most load fails first. So
Gotcha.
most horses with laminitis will rotate because horses are toe loaders. If you put horses on pressure plates, they load their toes. So most horses, when you give them laminitis, they're going to fail where there's the most stress. So since they're toe loaders, the lamina and the toe are going to pull apart and separate. And that's why the horse with two different feet typically will founder worse than the club foot, because there's more stress on the toe and the club foot.
So Bart alluded to this, different mechanisms. So we have the support limb laminitis. Sounds like it's just vascular stasis because the normal physiology has been disrupted. Now you have these other categories where, say, there's maybe some systemic inflammation. What's going on there?
Yeah, this is where it gets complicated, and all the answers aren't really there yet, but there's a lot of research going into it. For the systemic inflammatory conditions, like a horse with the colitis or pneumonia, typically there's a kind of a pro-inflammatory state, and there's normal enzymes in the horse's foot, metalloproteinases, that are designed for remodeling. So, when a horse's hoof, just imagine a horse's hoof growing down past the coffin bone. It's all lamina in there, but the hoof has to grow past the coffin bone. So there's a mechanism in place for lamina to intermittently let loose in a staggered way so the hoof can grow down the coffin bone. And this is done by metalloproteinases, and it's done in a very organized and staggered manner. They don't just all let loose at once. So every time a horse grows a little bit of hoof, you'd have laminitis. So it's done in a very organized way. But there's some condition systemically that turns on these metalloproteinases. It's thought, it's a hypothesis. There's a lot of studies supporting that. But they're turned on in a very unorganized way. So these metalloproteinases are letting the lamina loose all at once, and the horse gets laminitis. So it's a normal enzymatic event gone awry and uncontrolled.
Okay. And so that's the inflammation. What about you mentioned the endocrine issues that can lead to laminitis. So what do we think the lesion is there?
Yeah, the endocrine cases are a little different. They're a little slower in onset, a little more insidious in nature. The systemic inflammatory disease ones we talked about a second ago, those are scary. Those happen pretty quickly, like within hours or days, and those horses get very sore very quickly. These endocrine ones tend to be very slow onset. Sometimes you'll see some growth changes or some mild lameness, and it'll be very slow progression. But it's thought that these horses with endocrine problems have high insulin levels, and they do. They have studies showing, these endocrine horses have high insulin levels. They're insulin resistant. It's usually very hardy type breeds. Horses that are maybe not meant to thrive on these fresh green, very lush pastures, and like we have here in Kentucky. They're bred more for maybe more arid conditions, maybe living in deserts, so that's why we see a lot of these like ponies and these Spanish breeds typically get this kind of metabolic syndrome. And like I said, it's very, very hardy kind of horses. You see it in Morgans, warm bloods. Thoroughbreds probably the least likely to get it. I mean, they do get it, but they're probably less represented than the other breeds because they're not as hardy. But when horses have access to too much sugar, their body kind of gets numb to it. When horses ingest sugar, they release insulin, and insulin helps put the sugar back away into cells and store it for glycogen. And when these horses get too much sugar, they get insulin resistant, and their insulin levels get very high. So the body stops listening to the insulin, and high insulin has been shown in studies to create lamellar damage as well. And they've done studies, plenty of studies demonstrating that. Constant infusion of insulin will create laminitis. And even though the histological changes you can see very early on, usually the clinical signs are pretty slow and insidious, like I mentioned earlier. But the high insulin has negative effects on the lamina, particularly it causes some, it's actually interesting, the insulin story, because the lamina need glucose, like a constant supply of glucose. And So we thought, okay, the horses are insulin resistant. The lamina they're not listening to the insulin, so they're not able to uptake glucose into the cells. But interestingly enough, the lamina don't need insulin to uptake glucose into their cells. So they're insulin independent cells. So they don't rely on it. So that leaves questions. Why, if the basal cells of the lamina don't require insulin to uptake glucose, why are they having such a problem with insulin resistance, and why do they fail? But I think there's some hypotheses that insulin can act like insulin, like growth factor, and it binds those receptors on the basal lamina, and that has some negative effects on the lamina. So that has some effects on the cytoskeleton of the lamina. So it changes the shape of the cells, and the cells will stretch. So you have like elongation of the cells. And also those cells will reproduce in a very organized way. So you have this kind of thick, rubbery lamina kind of tissue that forms slowly over time. These horses get unstable, and the lamina can eventually let loose that way. You mentioned so it's very complicated, and there's a lot of research going into it.
Right. You mentioned these changes in endocrine horses happen over a prolonged period of time as opposed to the other types. When you look at these hooves, can you actually see any changes in the hoof wall that make you think, aha, maybe?
Yeah, there are. Okay, like I mentioned, the cells of the lamina will hypertrophy. They'll grow, but not in a very strong way, kind of like this rubbery, dysfunctional tissue. But you'll also see these horses, their chestnuts will actually grow too. You look at some of these insulin-resistant horses, and you'll notice that their chestnuts will grow quite longer than normal horses. And they'll need to be trimmed often. And even their ergot, behind their fetlock will grow. It'll be quite long. But on the hoof capsule, you'll see some changes. You'll see oftentimes growth rings. But more telling is on the solar surface of the foot, you'll begin to see a stretched white line. So you have this elongation of the lamina cells and hypertrophy of that cells, and that leads to a lamellar wedge, kind of this thickened lamellar tissue. And you'll see that on the solar surface of the foot on the white line. And that's something your farrier will probably pick up when he's trimming the foot. He'll say this horse has a stretched white line. You know what I mean? When you get radiographs or a veterinarian look at him. And depending on what the horse does for a living, it's just a pasture pet. Maybe no one's never noticed him being lame. But if you jog those horses or turn them tight, maybe sometimes you'll pick up some lameness issues eventually. But it could be kind of slow and hard to recognize.
So that's a really good explanation of the 4 causes of laminitis. So what are the outcomes? Because maybe I want to talk just a minute, because I think everybody's heard about sinkers and rotators and what the difference between that is, and maybe the significance of those 2 terms.
Yeah. So when horses rotate, the lamina just in the toe fail or let loose. So the coffin bone will actually just rotate. Sinkers are when lamina around the entire circumference of the horse's hoof are compromised and let loose, and the coffin bone will actually just drop straight down, or it can drop just to one side, to the medial side or to the lateral side. So like I mentioned earlier, I do think the lamina are compromised all the way around. They just fail where there's the most stress. And so you see club feet will typically rotate more readily than a very low-heeled foot. A lot of times I'll see those very low-heeled feet want to sink to one quarter or the other just because of their conformation and the way the foot's built. Their loading, the biomechanics of each foot are a little bit different, and based on conformation as well. Horses that toe in or toe out, may make them sink to a medial side or a lateral side, depending where most of the stress is. But some of these systemic inflammatory disease horses, they're pretty scary. I mean, they get showered with some kind of trigger factor that turns on these metalloproteinases, and sometimes they'll just let loose, all at once, and they'll be quite scary. And those are very poor prognosis, obviously.
Yeah, I know.
Because we rely on healthy areas of the foot to shift things to when we try to get them to heal, and those horses have nowhere healthy to shift them to when the whole thing's falling apart.
Yeah, that's always a fear for me with a bad colitis or a bad pneumonia, and they get sore, and you take the radiographs and you sort of, gee, I hope this thing's rotating and it hasn't just sunk. Yeah. Because, you're right. I mean, it's just so much worse. And those medial sinkers in my hands just, they're just real panic time for me. You touched on, before we talk about medical things, you touched on the mechanics. So if you're actually looking at this laminitic horse, how are you trying to trim or shoe or temporarily support this hoof in a way that gives you the best chance of success. So what's your thought process of how you set that hoof up mechanically before we think about anything medical?
So we're in the acute phase of laminitis?
Yeah, in the acute phase. My horse has just suddenly got sore. Yep. You're walking in saying, okay, this is what I want to do. So what's your thought process?
And in that, do these causes play into how you handle that? Mm-hmm. And your thoughts on prognosis?
Yeah, so on the supporting limb cases, since we know the deep digital flexor tendon pushes against those arteries and clamps them off, typically we do things to reduce tension on the deep digital flexor tendon in the supporting limb laminitis cases. So I will wedge them up. I'll elevate them to about 20 degrees. So the bottom of that coffin bone is about 20 degrees to the ground is typically what we'll do. And then, on those cases, other management things help as well. You want to get that horse to, there's very little there's very little ways to compensate for a horse that's not cyclically loading and unloading his foot. So, we're going to put something on his foot, but he's still going to be standing on it all day. So when you put a wedge on a horse's foot, we may enhance the perfusion to the toe by stopping that clamping off of the arteries, but we do put a lot of stress on his heels. So some of those cases will stop them from rotating, but then sometimes they may start to sink, to the medial lateral quarter. So these horses require a lot of monitoring, palpating their coronary band. So we're just shifting the load from his toe to his heel, maintaining perfusion to the toe. But sometimes those horses will start the lamina in the quarters will get tired and let go. So, and sometimes you try to catch those early, and you try to maybe decrease the height of the wedge, or maybe do more of a roller motion kind of shoe. But you really, hopefully, you can get those horses out and walk them if it's not contraindicated, depending what the other lesion is on the other leg. And doing things to facilitate the horse to use his bad leg. I think of like a radial nerve paralysis horse. We've had lots of success. Those horses can't really extend their leg, and they can't lock it in extension because they have a nerve paralysis, and they want to just drag it behind them. But we've had success on elevating the foot on the good foot, the supporting limb, raising it a lot, like 3 inches, so those horses are more likely to advance the paralyzed leg. Because a lot of those horses, not a lot of them, like in my experience, I think like half of them maybe do well, but I think the ones that you can get using it a little bit, it's like you get them using it and make it easy for them to use it, seem to recover a little better. Because some of those horses just give up. Mm-hmm. They like, I can't use this leg, I drag it around, and they just stop trying. So we do things to raise the other leg, make it a little easier for them to advance it. So limb length is important, particularly in those cases. But horses that have a cast on the injured foot, matching limb length is important as well. Make it easier for them to stand squarely and advance the injured limb.
And Bart sort of alluded to, the mechanics of like support limb laminitis as opposed to how you're trying to set up a endocrine or a infected inflammatory lesion. Any differences?
A lot of times we start at the same place with, since most horses with laminitis will rotate, we usually prophylactically treat them as if they're going to rotate. Mm-hmm. And then we change our plan accordingly, depending how things progress. So a lot of times we'll start them all off in a wedge, like I described for the supporting limb case. But then that plan changes if I start feeling like the quarters are getting a little ledgy, or I could feel some cavitation in the quarters, which may indicate they're trying to sink. Then sometimes I'll go from a wedge to maybe a foot cast on these systemic inflammatory cases. So it's usually a wedge at first, and then we change our plan accordingly depending on what the horse tells us. Mm-hmm. So there's no real crystal ball to tell, where the lamina are going to let loose first, except just looking at the horse's conformation and trying to see which lamina are probably the most loaded is a good starting point. Typically I'll put a club foot in a wedge, and if I have a low heel foot, a lot of times I'll put it in a foot cast on some of these really, really compromised cases. I'll treat 2 feet differently sometimes.
So how are you elevating? What kind of, describe the wedge you're putting on? You're not nailing a shoe on them.
No, we're using a cuff. There's different companies that make elevated cuff shoes. We're just bandaging them on because this is kind of a very you want to do something very quick. You don't want to hold the foot up too long on these compromised cases. You don't want to stress the other foot. So we try to do something very quick. We usually do a slip-on cuff wedge shoe with sole support, and then we'll bandage it on. And you want something you can change, because things are changing rapidly in these cases.
Yeah.
So if it's glued on, you got the sore horse, you're trying to remove a glue-on shoe, it's probably more traumatic than it needs to be. So I prefer to bandage them on in the acute phase.
So if they're already wearing shoes, do you leave them on? Do you take them off?
That's a good question. To me, it depends on the kind of shoeing job the horse has. Is he overgrown? Is the shoe cutting into his sole? Or is it a nice, tidy shoeing job with good support? Then I'll probably leave it. I don't want to create any more damage or stress with holding one foot up or pulling the shoe off. And sometimes I'll just add the sole support and the cuff wedge shoe over top of his nail-on shoe that he has on.
What else are you doing? Are you putting ice? We talked a lot about ice and
we talked about ice last time.
Those kinds of things. Do you want them?
I think for the supporting limb laminitis cases, I don't know if there's really nothing showing that cryotherapy or ice would be useful in those cases. But in the systemic inflammatory cases, for sure, icing's been shown. Cryotherapy, cooling the horse's foot down to 5 degrees Celsius at that high risk early phase, before they get foot soreness is very helpful and has been shown to either prevent laminitis or significantly decrease the severity of laminitis when they get it. So we'll ice those cases. When they're in medicine for, and they're showing these systemic signs and we think they're high at risk, those horses will get iced. Mm-hmm. They'll get foot support and ice will be that's our first thing we'll do for the feet, on all those horses' feet. Mm. And we'll ice them for 72 hours. Just constantly. We won't take them out. We won't give them a break.
So Peter, when you see a medicine case, what kind of cases would you look at that you go, this is headed towards laminitis?
Yeah, the bad colitis and the dynamite ones are like the Potomac horse fevers.
Yeah.
Those things just seem to founder at the drop of a hat.
Yeah, it's interesting why those.
I don't know.
I think male colitis is different, but those seem to be particularly susceptible to laminitis.
Yeah, they are. And you get a lot of endotoxin floating around, the bowels inflamed, but those Potomacs, I think it's just something to do with the organism, like maybe it just has more potent endotoxin that gets released as it turns over, but they're just dynamite. And you get a Potomac horse fever, very proactive with those ones, and you just cannot be quick enough with the Oxytet on those. If it's compatible history, shoot first, ask questions later with the Oxytet.
Yeah, I always tell our clients, we'll fix the diarrhea. Yep. It's can we save their feet?
Yeah.
That's the question.
And that's a huge prognostic indicator. If those Potomac horses start to show any foot problems at all, you start having a different conversation with the client, because up until the point, this organism is extremely sensitive to treatment. Fluid support, the diarrhea can fix that very quickly, but if they start to get any signs of foot issues at all, that just really knocks your prognosis all the way down. You may not lose them, but you may no longer have adequate athletic function because you're in a salvage situation. You mentioned the deep digital flexor tendon a lot, putting pressure on the vasculature. What can you do about that besides the mechanics of lifting it up? What other procedures involved in the deep digital flexor tendon are useful?
Yeah, well, so in severe cases that don't respond to the shoeing mechanics, and cases that are in the chronic stage of the disease now, with the bones rotated, there's a procedure where we'll actually transect the deep digital flexor tendon. So that's usually reserved for cases that are not responding to shoeing, or maybe the coffin bone has penetrated the sole, and it's considered an emergency to realign things and get them growing sole tissue over the tip of the bone quickly before they get a whole lot of bone damage. Those are two reasons we would use it. The third reason I would use it sometimes is economics. Maybe I've had this horse with endocrine issues for years and years, and we just can't get him out of shoes, and maybe the owner is looking for a way to have it be a little more cost effective long term. Mm-hmm. So I've had horses where I've told them we could probably cut his deep digital flexor tendon and maybe get him barefoot or into a normal shoeing program, rather than using these. Sometimes these shoes can be expensive, over and over again for life of the horse sometimes.
Mm-hmm. So what's that procedure, and what does it change that really makes the difference with these cases?
Yeah, so if you look at the biomechanics of laminitis, the coffin bone, it rotates. So now the bone's not parallel to the ground, the tip of the bone's pointing down towards the ground. And we'll do things shoeing and trimming wise to take tension off the deep digital flexor tendon because when that, when the lamina are compromised in the toe, that tendon's pulling on the bone, and the bone's pulling against the lamina. So, when shoeing mechanics fail, we can transect the deep digital flexor tendon, and that allows us to trim the foot and get the bone parallel to the ground almost we get it immediately, one way or the other, with propping it up with special shoeing. But we get that bone now parallel to the ground, and it takes a lot of stress off the lamina in the toe almost immediately, and it reperfuses the sole, the sensitive sole under the tip of the coffin bone, where they can start growing some sole again. Because when that bone's rotated, you got to imagine the whole coffin bone's surrounded by vasculature. If you do a venogram on a horse's foot, it's just a really very abundant vasculature. And when that bone's rotated, it compresses those vessels underneath it, and those horses don't grow sole. And when they don't grow sole, they get abscesses and chronic. They need to grow tissue to survive and replenish that tissue, and maintain adequate protection under the tip of the coffin bone. So when you cut the deep digital flexor tendon and do this realignment shoeing, we call it, we put a shoe on that gets the bone parallel to the ground. It really decompresses those compressed vasculature, and they get the healing quicker. So
you kind of take the opposite approach, right? Rather than raise the heels, now you're dropping the heels, raising the toe. Now
the deep digital flexor tendon is transected, you can no need for a heel wedge. You can just get them parallel right away. But shoeing and prior to doing the deep digital flexor tenotomy, there's lots of shoeing options we can use. I mean, there are you're trying to get that bone, in a horse that's rotated, you're trying to get that bone parallel to the ground with your shoeing, because you don't want all that compression under the tip of the coffin bone, compressing that sensitive sole vasculature. So you want to get it parallel to open up that compressed vasculature. But one way of doing that is trimming the heel down. But if you trim the heel down, you put more tension on the deep digital flexor tendon, and those horses will rotate more. So a lot of times it's trimming these horses to get them parallel to the ground, and then wedging the whole system up again. So you're trimming for alignment, and you're shoeing to address the deep digital flexor tendon and to give them support. So it's not just trim this foot and slap this shoe on. A lot of times we're trimming to align that coffin bone, and then we're trying to wedge it back up to address the deep digital flexor tendon. So it's multiple steps.
There's a lot of balance involved in that.
Does the end goal for the horse play into this? Say if I have a horse that a brood mare maybe that I want pasture sound versus an athletic performing horse, or do most of the time the treatment's pretty parallel to each other?
Yeah, I mean, pretty much parallel. I mean, if the way I treat them is I'm going to try shoeing first. I mean, deep digital flexor tenotomy, usually I try to save it for when I really need it and try to use shoeing. Once you cut the horse's deep digital flexor tendon, you're pretty much going to have a breeding animal or a pasture pet or a very light use horse. Not going to go back and be an athlete after the deep digital flexor tendon is transected. But I don't really like to do that unless I really have to, because there are complications when you cut the deep digital flexor tendon. Some of those horses will heal back. Once you cut that, you have two cut ends of the tendon, and that'll fill in with scar tissue. And sometimes that scar tissue could be a nasty thing. It can ball up and contract, and some of these horses can be good for a year or two, and then they'll start getting contracted on you from that ball of scar tissue at the cut ends of the tendon. So that is a complication we worry about.
So that's a salvage procedure, last ditch type thing.
Yeah, it is. Yeah, but I think when you have to do it, you got to do it at the right time. You got to do it. When a horse needs it, you got to recognize it needs it and do it. You got to know when you're failing.
Yeah,
you really got to. I mean, the horse will tell you, and you got to. We have different tools. We can, we monitor these horses with radiographs and venograms and their clinical signs. And if they're not marching along and showing signs of healing with shoeing, then I wouldn't drag my feet to do it. I mean, the procedure probably gets a bad name because people probably do wait way too long before they do it. These horses usually have badly demineralized, beat up coffin bones, been abscessing for 9 months, and then they decide they're going to, maybe it's time to do a deep digital flexor tenotomy. So the success rate of that procedure is obviously a lot better if you do it earlier, before you get some of those permanent changes to the coffin bone. Because I always say my number one goal is to maintain the health of the coffin bone. That's the foundation of the whole foot. So, if they're not growing sole and they're staying with poor perfusion and that bone's starting to get demineralized, a horse with a demineralized, beat-up coffin bone is going to be a permanent source of lameness forever. So I'd rather have a horse with a deep digital flexor tendon and a healthy coffin bone than a horse with a beat up coffin bone,
Right.
and a tendon we didn't cut. So you need to, if you there's a appropriate time to do it. It's a salvage procedure, but I try. We do it a lot quicker than before they get to some of those end stage events and permanent damage to the foot.
So medically, what do you like to see going hand in hand with what you're doing mechanically? What are the things that you're hoping we will do to help you?
For the endocrine horses, those are the most frustrating ones to me. Some of those horses are very hard to regulate their insulin levels. So I like to turf those to you guys when I can to manage their endocrine system, because sometimes that could be, we tell the owners, keep them off the lush grass and limit their carbohydrates. But some of those horses need some medical attention.
Yeah.
I mean, some of these horses, their insulin levels are 300, 400, 500, 600.
Yeah, it is hard
They should be 30.
Yeah, it is hard to sort of change that sometimes, because it really comes down to diet and exercise, and it's really difficult if you've got a painful horse because it's laminitic to exercise to get that muscle mass to sink the glucose, and it's also very difficult to get the owner to actually objectively look at the horse and not feed it as much as they think it needs, because that's defeated us a number of times, unfortunately, in that, you've just got to cut this thing down. It says, but you're starving my horse. It says, no, we're aligning its ins to its outs.
Yeah.
And it just can't take these carbohydrates. And there's plenty of feeds out there, and there's plenty of dietary ways to actually satisfy the horse for bulk while actually controlling the starch, because that is really the enemy.
Yeah.
Is trying to get that glucose under control, because unless you get the glucose under control, you can't get the insulin under control, and you can throw some medication at it, but ultimately not all of these are palatable. Like metformin is extremely useful, but the horses don't like it. I mean, it doesn't work forever. It's difficult to give in a lot of situations, and that's one of the best tools we have, but it's a short-term tool. I don't think it's a long-term management, because owner compliance becomes difficult.
Yeah. Yeah, we have to get them comfortable and exercising and moving around is so important.
Yeah.
A lot of these horses are that we get like that are pasture pets. Some of them don't even ride them. They just, their job is to sit out, in a small paddock out front of the house. So, if you can get owners to exercise them somehow, once we get their feet stable enough, that would be a huge plus.
So you talked about you're supporting limb laminitis. You want those horses moving if you can. What about your bilateral laminitis cases? What do you want them doing?
Yeah, I mean, it depends how stable they are and what stage of the healing process they're in. These endocrine horses, they tend to be, these metabolic type horses, they tend to be very hardy horses, like we mentioned earlier, and they usually have very robust, strong feet. Sometimes I find these feet fairly easy to work with, because they have good, strong walls, nice, robust, strong, good, hardy feet. So I like to get those horses comfortable and make sure they're stable. How do we know they're stable? A venogram is one good way of knowing if they're stable. We can put a tourniquet on at the horse's fetlock and inject some radiopaque dye into the foot and shoot a radiograph, and it gives us an outline of all the blood vessels of the foot. And if those horses are unstable, they'll be shut down. There'll be no perfusion in certain areas of the foot. Those horses, obviously, you don't want to exercise them or move them around, cause more damage. So those horses you would treat for a little bit longer with different shoeing mechanics, and maybe repeat the venogram and see if they're stable. Another way you know a horse is stable is if they're growing sole and wall. I mean, when the bone's not stable and it's pressing on that sensitive sole tissue, that sole's not going to grow. So the hallmark of stability to me is tissue growth. So when they're growing sole and growing wall, and their comfort level too. But some of these metabolic horses could be very difficult. You can grow a lot of sole on them, and they can be growing good foot, and everything looks stable, but sometimes they just stay sore. And usually you pull blood on them, and their insulin levels are still high. So we've mechanically got these horses doing well, looking great on radiographs, but I got several cases I can think of now where they just stay sore because their insulin levels aren't being controlled.
Yeah.
So we can max out our mechanics and do all these great things, but they got to treat the primary problem.
Speaking about problems, is it possible that some of these modes of laminitis you talked about can occur together? Because my nightmare scenario is the aged mare who's insulin resistant who retains her placenta. Because these come through the clinic, right?
Yeah,
I mean, these 17, 18-year-old mares just getting that last foal out, and they retain their placenta, can maybe have dystocia. You know they're sitting on a knife edge as far as insulin resistant goes. All mares get insulin resistant from about 280 days gestation anyway, so you're just piling normal pregnancy physiology on top of their perverted physiology with their insulin anyway, and then they have an infectious inflammatory hit, and then they start to rock forward or back depending on where it hits them. And so how do you manage that horse that's potentially got all the mechanisms that you've talked about playing on at the same time? Which battle do you fight first?
Yeah. No, I mean, we definitely see those cases where the feet are already compromised to begin with, and just it lowers that bar for the next insult to put them over the edge. I mean, mechanically, I don't treat them a whole lot different. I mean, I kind of treat them just how I would with if they're already rotated. So you have the chronic case that's already rotated, and it comes into the clinic for a retained placenta and starts to get acutely laminitic again. I mean, I treat them. My trim would probably be a little bit different. I'd probably set that horse up a little different. My trim first. I'd probably, if the coffin bone had a high palmar angle and was pointed towards the ground, the horse would get a big heel elevation, but I'd probably trim him first to get that coffin bone more parallel to my shoe. So it would be an emergency kind of heel wedging, but my trim would be a little bit different. But I've seen metabolic horses also get supporting limb laminitis, or maybe a metabolic case that was foundered in both feet. One foot was a clubby foot. He got really, really sore on the clubby foot because it rotated more, and now he bears all his weight on the other foot, and he's getting a supporting limb / endocrinopathy as well, laminitis. So yeah, they don't all shoot straight. They throw us a lot of curveballs. That's for sure.
I mean, they don't all fit neatly. It's good to categorize them in your mind, but some of them just don't sit easily into one shoebox. Yeah. I mean,
the majority of laminitis cases people see are the metabolic, the endocrine one. I mean, I think I read a paper where I think if you look at all the laminitis cases all around the world, I think it's like 90% of them are in that category. Maybe not us here in Kentucky. I think our numbers would be a little different. With the breeding population and the thoroughbreds. But
the horse population, like the human population overall, is getting older. Geriatric medicine is more of an issue. So I'd agree with you totally. When I worked in Pennsylvania, I mean, I'd see sometimes 2, 3, maybe Cushingoid / metabolic horses, new cases a day, because it was the land of the aged horse, which was like a big dog. And there was just so much of it. You didn't see so many of the other things. But you're right, here with the population we have, it's more of the other problems, right? The sick horses having issues, or the support limb post-orthopedic things.
And the way we treat them, the way we feed them, I mean, it's like 3 meals at the Golden Corral sometimes. Yeah, it is. Yeah, there's a burger joint on every corner. And you're talking about the horses, the things that worry me, as you say, horses that evolved like we did in the harsh climate when you didn't know when your next feed was coming from, like little Shetland ponies, those sorts of things. All of a sudden, there's food everywhere, and they're just not set up for that. They're supposed to be nibbling a piece of seaweed on a rock on the Scottish coast, right? And now there's just luxury food, and then it's no wonder they just blow apart. And you know what I mean? As the saying my dad has, you dig your grave with your knife and fork. And I think people do that to their horses. They just, food is love, and I love my horse.
Diet and exercise.
Diet and exercise,
This time of year scares me a little bit with just speaking of metabolic. I mean, we don't see a whole lot of metabolic in thoroughbreds, but I seem to see it in stallions. And I see it this time of year for some reason. It seems to be in the autumn and fall.
Really?
Yeah, when I have flare-ups, it seems to be, I don't know, it's just because they're breeding in the spring. The spring grass is dangerous. The grass after the first frost is dangerous as well. It gets higher sugar content. We just had our first frost last night. But I don't know if these stallions, they're breeding. Maybe they're burning more calories in the spring. Now they're kind of sedentary. Maybe they're just kind of chilling out and getting turned out and eating grass. And the sugar levels in the grass this time of year are dangerous as well. But I seem to have flare-ups in stallions this time of year.
Unless people are trying to put some weight on them before the winter period, so they can roll into the breeding season with a bit of extra condition on.
That's another thing with the endocrine. It seems to be the fall. Like horses are getting ready for the winter with these endocrine problems. They're just getting more efficient it's like they're getting ready for hibernation
Yeah.
or no grass
Yeah.
mode, less grass, and they
Yeah.
store up. Their body's getting ready, and
Yeah.
it's a scary time of year. The fall has always been, we always talk about the spring
Yeah.
being
Yeah.
a bad time for laminitis. I mean, I see a lot of new cases, but I have a lot of setbacks and flare-ups.
Things come out of control in the fall.
Things in the fall.
Yep.
It's weird. I mean, it's been a pattern for sure.
Yeah, and this year it's been warmer for longer.
Yeah.
And right, so
Yeah,
things have
and
been
we've got way more grass out
Yeah.
there than we usually have. So
Yeah,
it's greener for longer before that frost has hit. So I'm sort of thinking, "Ugh."
yeah.
Oh well.
Guns loaded. I mean, it's like, it's a perfect storm.
Yep. Well, I mean,
We'll really monitor our horses this time of year. Any ones that have cresty necks or stallions that are looking a little overweight and get that phenotype of any kind of endocrine phenotype, like a cresty neck or abnormal fat deposits, we'll pull blood on them and check them, and maybe they go to a muzzle, maybe they get limited turnout.
yeah, I'd say
You got to be very proactive this time of year.
Yeah, I think it'd be time to be liberal application of the grazing muzzle, especially this year, because that's the thing. I mean, the horses, they're just out there just mowing this grass down, and everyone's thinking, "Oh, my horse looks good," but it's also eating sponge cake.
Yep.
do you like sponge cake?
If it's cooked right.
Yeah, I
There's
would.
nothing like a good Victoria sponge. You go to England, they cook one of these Victoria sponges,
Yeah.
and it's got lots of little cream and a little bit of jam on it. Just
I've never been a
little
sponge
bit
cake
of powdered
fan.
sugar.
It's hard for me.
Really?
Yeah,
Ah.
no, just raised on chocolate, I guess.
Yeah, well, there's worse things to happen.
Pizza for me. I'm
Pizza?
on Pizza.
Yeah, well.
I can have it for dinner and dessert.
Well, pizza's a vegetable, right, with that tomato paste on it. That's what you're told. Excellent. Now, any questions?
No, I don't think so. Thanks, Scott. That was very thorough, and
Thank you.
I appreciate you being here with us today and shed some light on some things.
Yeah.
Thanks for having me.
Yeah,
Appreciate it.
it's really helped, sort things out. And in my mind is, what your approach is and how you look at the different categories and how you approach them. Because, I mean, we lean really heavily on you guys for the management of our cases when they're really sick, because the number of times I have this really sick horse come in, I think I'm just getting out of jail, and all of a sudden it starts rocking back, or the pulses start to come up, and it's a fear we always live in, right?
Yeah,
is that you're going to win the battle, but you're going to lose the war, because you're just going to lose those feet. And horses, if they're set up, if there's an underlying issue, one little challenge uncovers it, and then away you go.
Yeah.
Yeah, and it's a stressful time, not only for a veterinarian, but for owners. And having you guys who've seen that so many times before to be, tell us to hold on, we can get around this corner, and just knowing when it's time to stop too is important.
You don't know what the disease, you don't know the future, what the future is going to bring. You don't know where that disease is going to take you.
Yeah.
There's so many different outcomes, and like I said, the whole horse's future is in jeopardy when you're faced with that situation.
Yeah, and the thing is, there's a whole lot of pressure on 4 little things.
Yep.
That's a whole lot of horse.
Yeah.
Excellent. Well, we've been here with Dr. Scott Morrison of the Rood and Riddle Podiatry Service, sharing his wisdom on laminitis. See you next time.